So with that in mind, we move to the last presentation of this session, which is from Professor Doug Thorburn, who is a consultant hepatologist at the Royal Free in London and who is the chair of the Liver Advisory Group, who's leading the EMPhatic study to look at transplant in HYLA, and he's going to give us a general update on liver transplant for cholangio.
Good afternoon. I'm Douglas Thorburn. I'm providing an update on the UK situation around liver transplantation for cholangiocarcinoma. I'm sorry I'm not able to be with you at the meeting. I've got no declarations in relation to the presentation. There are in the UK 2 pilot programs of liver transplantation for cholangiocarcinoma, one for small intrahepatic cholangiocarcinoma and the other which is due to open shortly for perihilar cholangiocarcinoma in the background of primary sclerosing cholangitis. These 2 pilots have been established along with a range of other pilot schemes for liver transplantation within the UK. And these are indications where acceptable outcomes have been achieved with liver transplantation in other countries. And what we're trying to do is establish if these similar outcomes can be delivered within the UK as part of a national programme. It's not research, but there's a caveat I'll come to in particular in relation to perihilar cholangiocarcinoma. And there's examples there of indications that have become routine now indications, and other pilot programmes that are open for neuroendocrine liver metastases and for isolated colorectal cancer liver metastases, and those pilots are underway at present. So the first indication that I updated on last year was very early intrahepatic cholangiocarcinoma. I'm not providing the evidence here, but just outlining the category of patients with this form of tumour that would be considered eligible for liver transplantation within the pilot. It's a single tumour, less than 2 centimetres. There needs to be a background of chronic liver disease. They have to be irresectable as determined by the HPV-MDT. And there's a specific exclusion around mixed tumours, cholangiocellular, hepatocellular. The pathway is after staging, transplant assessment, listing. The aim is to have the patients transplanted within 3 months, and they're restaged on a 3-monthly basis thereafter. The scheme opened in February of 2023, and thus far 2 patients have been registered, and both of those patients have been subsequently transplanted, one in August of 2023 and the other in December of 2024. And both of them were transplanted with so-called cardiac death donors, and this was outside the offering of the standard DBD donors that are offered through the National Liver Offering Scheme. And the outcomes for these, both these patients at 3 months and at 1 year are thus far favourable. As you can see, however, there's been a relatively low accrual into this pilot so far. And a recent fixed-term working group has been established to review all the new indications and consider such things as the rate of accrual. And we specifically looked at that in relation to intrahepatic cholangiocarcinoma, and we've revisited the criteria that would allow patients to be included. And this has resulted in a recommendation to expand the criteria as a single tumour up to 3 centimetres in size, which is in line with the EASL and ILCA guidance. Some other recommendations around undertaking a lymphadenectomy at the time of surgery, the ongoing recommendation of macrovascular and poorly differentiated tumours being excluded, and still recommending that the mixed tumours are excluded. And then some issues have arisen about the treatment of patients with the intrahepatic cholangiocarcinomas in terms of bridging therapy and in terms of systemic therapy. And we've come up with recommendations around them. there's a feeling around the issue of stakeholder engagement that this shouldn't be a particular issue, or it's not a primary problem in relation to intrahepatic cholangiocarcinoma. But there is a need to more generally increase awareness around the new indications. And there's a thought that this is in particular in HPB cancer centres that are not linked to liver transplant centres or are not liver transplant centres. And if these recommendations are adopted, and this will probably be determined at the May LAG meeting, then there would be a process of re-advertising this and redissemination to the updated criteria. In terms of how we offer organs, there's no specific recommendation to change that, but there is the suggestion that we need to consider the use of a wider range of what we would call more marginal donors. And in the two cases that have been transplanted already, they've already been transplanted with expanded criteria with DCD donors. So I think that in effect is already occurring. When it comes to perihilar cholangiocarcinoma, this is based on the initial protocol from the Mayo with the selection of patients with a single tumour less than 3 centimetres who undergo neoadjuvant therapy with radiotherapy in the form of brachytherapy, and then a staging laparoscopy and ongoing chemotherapy until the time of transplant. And they've, without going over the data, the justification for this is the favourable outcomes that have been achieved with this rigorous selection of cases. It's also worth highlighting that in the UK we've selected patients with PSC with perihilar cholangiocarcinoma on the background of PSC, as that's a group of patients where the outcomes are more favourable from the international data, around a 70% 5-year survival and a lower rate of recurrence, around 20% at 5 to 10 years. It's really important to highlight the reason for the neoadjuvant therapy with chemotherapy and brachytherapy, because in the absence of that, has been highlighted in this meta-analysis of large series of patients transplanted with perihilar cholangiocarcinoma, the 5-year outcomes of those transplanted without neoadjuvant therapy, including brachytherapy, are really unacceptable, because we have to target outcomes of greater than 50% 5-year survival after transplantation. And that's why neoadjuvant therapy is recommended. Now, in the UK, because we've not got brachytherapy, the route that's been recommended by the development group for this indication was proton beam therapy. So the inclusion criteria within the UK pilot are those patients with a dominant hilar stricture, a mass less than 3 centimetres, and there needs to be confirmed histology, and there's a number of exclusion criteria that are listed below. Within the protocol, the neoadjuvant therapy that they receive is proton beam therapy, PBT, that's recorded here. Now, PBT therapy is not commissioned for patients with cholangiocarcinoma, and certainly not within a liver transplant pathway. So the only way that we've been able to develop this is within commissioning evaluation. I'll go on to say more about that. But after the neoadjuvant therapy has been delivered, they are reassessed, listed, and will have ongoing chemotherapy as standard of care after transplantation. This, as I mentioned, is having to be undertaken in the form of a clinical study at the request of NHS England, but funded by NHS England. And this will, as a consequence, if we can demonstrate delivery against the primary outcomes of the study, should allow us to get this adopted and commissioned as routine clinical care in the future. And because this, the emphatic element is around the proton beam and neoadjuvant therapy, The CI for the study is Professor Maria Hawkins from UCL. This is one of a number of commissioning evaluations that's being undertaken for proton beam therapy in the UK. It's expected that around 50% of capacity will be for routinely commissioned PBT, but the remainder will be for clinical trials, mostly in RCTs. These ESIT programs that have been developed, like Emphatic, it's not felt that it's reasonable to undertake a randomized control trial. So it's being undertaken as a single-arm protocol with all patients being exposed to the proton beam therapy. And it's really a proof of concept safety study to look at whether this neoadjuvant therapy can be delivered with acceptable tolerability and safety, but also that we can actually get patients to the point where they undergo transplant. And it's one of 4 evaluations. It's the only one where it's a neoadjuvant treatment, and we're at the forefront of getting this study opened versus the other 3 PBT evaluations that are underway. The pathway will involve the patients, regardless of where they come from, going to the 2 proton beam therapy centres, one at the Christie and one at UCLH, and they will undergo the neoadjuvant PBT there before they're returned locally, and will have their ongoing treatment on the list at the local transplant centre. And there's 7 adult liver transplant centres within the UK. In terms of the outcomes, as I've mentioned already, the primary endpoint is the number of, or the proportion of patients who have significant toxicity after neoadjuvant therapy and liver transplant, and also what the rate of dropout is, so the proportion of patients successfully going on to undergo liver transplantation. And then there's a number of secondary endpoints, in particular looking at broader outcomes. And of course, as transplant clinicians, we're interested in what the outcomes after transplant are, but that's really a secondary consideration in terms of the Emphatic study. So it's been quite a long time in setup and development. These ESIT programs commenced in 2022, and sponsorship of the program was in 2023. There's been a long lead time in getting things established, and we have and we've got to give thanks to Sally Falk and Romilly Rao, who've been leading in terms of getting all the paperwork completed to take us through to the point that the study was opened. It will be opened. This includes achieving ethical approval and the process of setting up the studies within the 2 proton beam centres. So into 2025, the remaining steps are listed here, most of which are well underway. A really important one are the developments of the PBT process and technical developments of the protocols. And the reason for this is, as I've mentioned, cholangiocarcinoma and liver treatment of liver cancer is not an accepted indication in the UK for proton beam therapy. So the treatment centres have not developed the protocols to actually deliver the treatment, and therefore there's a learning curve in terms of treatment planning, and the treatment planning that needs to go into the development of these the protocols within the PBT centres. And all this is underway and anticipated to be completed within the next months. So in terms of the final steps to opening, the local approvals that I mentioned within the PBT centres, but also establishing the liver transplant centres themselves as PIC sites, just meaning patient identification centres, because it will be the liver transplant centres that are working up and assessing the patients, but referring them on to the treatment and trial centres to have treatment. So that's been underway since November and is progressing smoothly. we're requiring sponsor green light from the sponsor to then open, and it's anticipated that with these final steps completed, that should be open to recruitment in approximately June. We're anticipating June as of discussions that have taken place in the last weeks. In terms of accruals thus far for patients with perihilar cholangiocarcinoma, there's been one patient that's been registered with this indication. That patient had proton beam therapy out with Emphatic, so not within the clinical trial. There was an appeal sent to the Liver Advisory Group, which was supported by the sufficient adult centres to allow the patient to be registered, and they were listed for liver transplantation last month, and they're currently active on the liver transplant waiting list. So while they won't be able to be included in the Emphatic study, there's at least one patient has at this point been taken through to the point of registration. So in terms of the live issues beyond that I've described, very briefly I was wanting to touch on a couple of a few items in the last few minutes. The first thing is to describe the situation with liver transplantation, where since COVID we've seen quite a significant reduction in the amount of liver transplantation undertaken compared to the 2019-20. So there's been overall a reduction around 5% in the number of liver transplants that are undertaken, but there's also been an evolution from in the type of donors that are being used with now approximately 50% of the donors in the UK being within the DCD category, which, as I've mentioned already, are considered to be the more extended criteria, and when in the past it was only about 30% of the donors that were DCD. So there's been a significant growth in the number of transplants highlighted in grey here, in the number of patients that are being transplanted with DCD donors, and there's been around about a 30% reduction overall in the number of DBD donors that are available. And as a consequence, if we have very restricted criteria about what types of donors we're going to use for patients with cholangiocarcinoma, unfortunately, we're really going to struggle to get these patients transplanted. And it's also to highlight that overall, as a consequence of this reduction in transplant activity, what we've seen is since in the last 7 or 8 years, a growth in the number of patients on the waiting list. So it's increasingly competitive to get patients transplanted, and that's in the context of trying to develop these new indications. The other thing I was briefly wanting to highlight was this issue. I've already mentioned the perihilar transplants are going to be undertaken only in patients with PSC. This was a paper that was published in 2022, which was really a retrospective audit of incidental cholangiocarcinomas that were identified in people that had undergone a liver transplant in the UK. About just over 60% of those patients that were transplanted had PSC. And what was shown was that of those patients that had incidental cholangiocarcinomas, only about a third of them had T1 tumours. So there's a real issue, I think, in survey and identify cholangiocarcinoma in these patients. And so now that there is the opportunity to undertake liver transplant for patients with early stage disease, there's an increasing onus on us to improve our ability to detect these tumours at an early stage, and is to highlight that this isn't a problem that's confined to the UK. There's an international problem about the optimal surveillance techniques and the evidence to support the surveillance techniques for patients with cholangiocarcinoma. Another issue that's live is the complete for the perihilar cholangiocarcinoma, not just in terms of the centres that are involved and the MDTs that are involved in the identification and recognition of these patients before considering them for putting these forward for evaluation. But once they have been identified, the process, as I've mentioned, of once they've been determined to be appropriate, getting them to the PBT centre, delivering the neoadjuvant therapy to the patient, and getting to them through the reassessment and getting them listed and transplanted. And as I mentioned, this is one of the primary outcomes of the study, is how many of these patients can we get to the point of being transplanted. And so we're really going to have to refine these pathways within the transplant centres. And we've got, with the impending opening of this protocol, we're going to undertake a series of discussions with the individual transplant centres to see if we can learn from each other about how we can ensure these this pathway is, when it opens, is as smooth as it can be, and learn from each other and how we're going to do that. The final thing I'm going to mention is ensuring equity of opportunity and how we'll monitor the pilot. So one of the concerns when the pilot was being developed was, given that this isn't an agreed commissioned pathway, would all the independent health systems within the 4 nations accept this and support funding this over and above NHS England's commitment to do so? And the fantastic news, and we've got to thank Adrian Crellin for his support with in achieving this, we've got agreement from all 4 nations that they will ensure that their patients are going to be eligible to be treated by this pathway. The next thing is, and I've touched upon already, the issue of raising awareness. We've got this series of meetings with the transplant centres to try and highlight this pathway, discuss some of the complexity that sits behind it, try and ensure that they're thinking about how they can establish this pathway within their own centre. As I mentioned, this involves a whole range of clinicians that wouldn't necessarily normally be involved in the transplant process, like the PB medicine colleagues that will be undertaking ERCPs and EUSs. And just for everyone to understand how we have to be time efficient to allow these patients to get through to the point that they can be registered and transplanted, and thinking of ways on these complex pathways to make things as possible. There's also the need to engage with non-transplant HPV cancer MDTs, and I touched upon that with the ICCA indication. Also the wider clinical community to raise awareness, and the patients and patient support groups, so to ensure that they are aware, and I guess this talk is an opportunity to do that. The final thing to say is that once the pilot's open, the pilot is for approximately 30 patients, and the progress of it will be monitored via LAG. This is the pathways for each of the pilot indications. For this specific indication at the moment, we're not proposing a national MDT, but there would be an oversight group, and in effect we think that the implementation group that was established that developed this indication will become a oversight, steering or reference group to support the indication out. And of course, as the emphatic is a clinical trial, written into the protocol was the method of monitoring against the outcomes, which will be largely undertaken by the 2 PBT treatment centres. And we already have a well-established transplant registry, which will give us outcomes on the patients who have undergone transplantation for this indication, and that data is collected routinely on all patients that are on the waiting list. So just finally, to thank all the people that have been involved. I've particularly mentioned Sally and Romilly, Rhiannon, who's been instrumental in helping harmonise the data collection between the transplant registry and the emphatic study centres, Raj, who chaired the implementation group, Nigel, who chaired the development group, the PPI input that we've had from Martine and Helen, and all the people worked so hard to help us develop this indication and see it to the point of that we've reached just now. And with that, I'll conclude. Thanks again for the invitation to speak, and apologies that I've not been able to join you on the day.